Yeah, thank you, Casey. Thank you, everybody who has logged in. And as you know from the title, we're going to talk about partial knee replacement versus total knee replacement. In orthopedic world, we call them unicondylar knee arthroplasty and total knee arthroplasty. As you all know, knee has three parts. Is the inside we call medial joint, outside we call lateral joint, and the kneecap, or so-called patellofemoral joint. So unicondylar knee replacement can replace any of those three things one at a time. Total knee replacement usually replaces all of those three. So what is unicondylar knee replacement? And I know some of these slides may be technical. I will do my best to try to explain them, but please stop me if you don't understand any of these, and if you want us to explain them, I'll be happy to explain. So unicondylar or partial knee replacement was introduced in 1972. The initial knee replacement or the partial knee replacement wasn't perfect because the plastic was flat. But we all know that our knee has a dish to it, or what we call congruent. And the flatness of the polyethylene made it very prone to having issues in the beginning. And the sizes or the thicknesses of the polyethylene was 7.5 millimeter, 9, 12.5, and sometimes custom made. And initial results that were published in 1976, this is from New York, Dr. John Ensel, who was one of the pioneers of knee replacement, his results were not that great. The medial or the inner joint, only 32% were good, and the lateral ones, only 40% were good. Obviously, that is far from acceptable. But modern partial knee replacement, I'm going to try to convince you that is better than total knee replacement. So what about knee replacement? Knee replacement is a great operation, but a group of institutions, including us, got together and we had a third party call the patients up. This is all the patients that have been operated on these various institutions, and ask them how they felt about their knee replacement. And what we found was majority of them were happy. They were glad that it was done, but some of them were still having some issues, including getting in and out of car, etc. And we published this paper back in 2014, and it's been cited many times as a justification for knee replacement not being a perfect operation. I think it's almost there, but it's definitely not like unicondylar knee replacement or partial knee replacement. You all know our knees inside it has two cruciate ligaments, ACL or anterior cruciate ligament, which is this one, posterior cruciate ligament or PCL, and those provide what's called a 4-bar linkage. The great thing about partial knee replacement is that you don't take either of those ligaments out, and hence the knee still has the same stability as a native one, and it definitely has that 4-bar linkage. And because of that, patients actually feel their knees more stable. They feel their knees more natural. They prefer them to a total replacement. We have studies done where patients had partial replacement on one side and a total on the other side. 99% of those patients preferred the partial versus the total. It conserves bone. You can do partial knee replacement without cutting much bone out. And as I said, it does retain the cruciate ligaments, which provides more and normal kinematics. The results, there has been numerous studies published in some series, 5-year, 10-year survivorship. By that we mean the chances of the knee failing and needing another surgery, 96, 97% survivorship at 10 years. So the modern knee replacement definitely works better, and partial replacement obviously has better outcome. But there are some studies in the past that have shown that the partial knee replacement isn't great. Again, this is another 1976 paper. We won't dwell on it too much because this was, again, the old generation of partial replacement. And these patients didn't do great because most of them were having a problem in their kneecap. And about 63% of these patients didn't even have a kneecap when they underwent partial replacement. In today's world, we wouldn't do partial replacement in somebody who doesn't have a kneecap. Who would you do a partial replacement on? In the old days, it was described that it should be for the elderly people, low demand, patients whose weight was very low, they had very good range of motion, and they didn't have too much deformity, and they had their cruciates intact. In today's world, that doesn't apply. It's for just about anybody as long as they don't have arthritis in the other two compartments. So if the arthritis is confined to one compartment, then you can definitely do a partial knee replacement for those patients. I will accept a little bit of arthritis in the kneecap, a little bit, as long as it's in the medial facet, which is basically on the inner side of the kneecap. And I think it's okay to do it for patients who have a stable knee, even without the ACL. But I think it's not a good idea to do it in patients who have a knee that does not straighten out, what we call flexion contracture. And patients who have severe bow-leggedness is also not a good operation because this usually does not address the deformity completely. It is probably also not a good idea for patients who have gout or pseudo-gout, patients who have a Charcot disease. These are patients whose knee has no feelings and it destroys itself. Patients who have avascular necrosis or osteonecrosis, when the blood supply to the bone dies out. And inflammatory conditions. Probably those patients won't do very well with a partial knee replacement. What we can't do with a knee replacement, partial knee replacement, is we can't correct the deformity too much. Not because we can't, but we don't want to correct the deformity too much, and I'll show you in a second why. We also don't want to do this operation for patients who have very, very poor range of motion, extremely stiff knees. And again, if they have a knee that doesn't straighten out, so-called flexion contracture, we wouldn't do it for them. And if patients have an instability of their knee and the knee moves in all directions, also not a good operation. How many patients who have arthritis of their knee qualify for a partial replacement? But if you look at this early study in 1993, only 6%, 13 out of the 228 patients were eligible for unicondylar knee replacement. But this was the eligibility based on the old criteria that I showed you earlier. In today's world, we don't use that old criteria. I will do a partial knee replacement for a 45-year-old. In fact, I will argue it's a better operation for a 45-year-old than a total knee replacement. Another study showing only 8%. Again, this is another study from almost 22 years ago. In Europe, 25% of patients who have arthritis of their knee receive partial knee replacement. In my hands, about 30 to 40% of patients who have arthritis of their knee are candidates for unicondylar knee replacement. There are different types of knee or partial knee replacement in the market. I will tell you that there really is not much of a difference between them. What really makes the difference, which is also true for a total knee replacement, is your surgeon. A surgeon who knows how to do them and knows how to place them and to balance your knee should most likely have a great outcome. But the two different varieties are called fixed bearing and mobile bearing. What that means is that this is a picture of a partial knee replacement. This part goes on the femur, the thigh bone. This part goes on the tibia, the leg bone, and these are the plastics. Now, the plastic, fortunately, in this particular setting, sits inside and doesn't move. That's called fixed bearing. It provides better fixation, but the disadvantage is that because of that metal here, the plastic may be thinner. The mobile bearing is that this part, this plastic, moves on that tibial component. And maybe this has better outcome in terms of less loosening. But these are technically more demanding to do, and sometimes they fail earlier. Based on studies that are done, there really is no difference between fixed bearing versus mobile bearing. What really, again, makes the difference is the surgeon and who did it. How do you do it? Well, partial knee replacement, these are the trays that we have in the operating room. These are what we call instruments. And first, we make a very small incision. This is 1/3 of the size of an incision that you would see for a knee replacement. We expose the knee. So this is a right knee. This is where head is. This is the leg. Knee is bent. This is the thigh bone right here. This is the leg bone or the tibia. And you can see there's no cartilage on it. This is all worn out. What I usually do, as soon as I open a joint, I take a look at the other compartments of the joint as well to make sure that the other joints are intact and they're in good shape. And if they are not, I sometimes decide to convert to a full replacement. So I don't just go there blindly, concentrate on one compartment, ignore the others. I will look at those, I will look at the ACL, I will test the knee to make sure it's stable, etc. And majority of the time, if we have chosen wisely, that's going to work out fine. Then we put a special jig. This is called a jig or a guide. Then has different parts to it, gives us the ability to decide how much of the leg bone or the tibial bone we need to remove. We make sure that we protect the ACL and PCL when we're doing that cut, and we remove very little amount of bone. Once that's removed, we also get to the back of the knee and remove all the bone spurs or so-called osteophytes. All bone fragments have to come out. Then we start to do balancing and checking the alignment of the knee. And I won't bore you with the technical detail of this, but this step is very, very critical. Then we put a special type of a guide and cut the femoral or the thigh bone, as you can see here. And once we remove all of that, the components can be placed, the trial components, but we remove, again, all the bone spurs to make sure that the area, this is the bone that we have now got exposed, that's the other area of the bone that's exposed. We then put these trial components. These are the temporary parts that we put in. We check the range of motion to make sure that the knee moves, straightens out, and bends very much. It's stable. There is no floppiness to them. And then if that's the case, we remove those and put the final components in. If that's not the case, we have to make some adjustments, maybe increase the thickness, maybe increase the size, maybe change the position, maybe release a little bit more of the ligaments, maybe tie down a little bit more of the ligaments. So various strategies where we have to get that balance right. And then we bend it, we straighten it, we take a look at it to make sure that it all looks good. And if it does, we would then remove them and put the final components in. And these are the final components. And we then irrigate the wound with some povidone iodine and then close up. Usually it takes about 30 minutes, maybe less. This is what we call a tourniquet time, when we apply tourniquet to the leg while we're doing the procedure to reduce blood loss. So about 30 minutes. In half an hour, arthritis is gone and the patient has a new partial replacement. Total replacement usually takes longer. It's more technically demanding. It requires more of a balancing act, etc. So are there any issues with partial knee replacement, and have there been bad results with the partial knee replacement? Yeah, just like total knee replacement, there have been some bad results in the past. But again, this particular design had very, very thin polyethylene. This particular polyethylene was gamma irradiated, which means too much X-ray exposure during the sterilization process. which then led to some defects in the plastic, and the plastic then ended up being sort of falling apart. Then others that they say that some people say it's less predictable than total knee replacement, and knee replacement provides better alignment. I think that's fair. With a knee replacement, because we're removing all three compartments, we can correct the deformity more, but because we want to correct the deformity more. But with a partial knee replacement, you don't want to do that. So here is an X-ray. This is the right knee, and this is not one of my patients. Obviously, this is the one that was referred to me. If you look over here, the knee is in what we call a knocked knee position. Knee should not be in that position. Knee should be straight and not pressurized. So what has happened here, because of a very thick plastic that they put into that partial knee replacement over here, the knee has been pushed into what we call valgus or knocked knee, and the area over here or on the partial on the outside then is under too much pressure, which then leads to the arthritis. And as you look over here, and not so long after the surgery, that patient has developed arthritis, and these are bone spurs and the joint space is narrower. So that patient then needs to have a total knee replacement. Or you can sometimes leave it undercorrected. In here, this was not technically done right. The patient has developed loosening and part of that bone unfortunately is breaking. And that's what we call undercorrection. Again, that needs to be converted to a total knee replacement. Sometimes the surgeon is too aggressive and removes too much bone. Over here, too much bone has been removed, and actually a little bit of cement has been left back in the back of the knee as well. And here, this is far too much removal of bone. That leads to a problem in the future, and those then fail. You need to make sure a partial replacement that your surgeon uses has good plastic or good polyethylene. Technically, the surgery needs to be done well, so you can't afford to have pieces of cement left behind, because that could increase the wear of the plastic. And we also need to have components available for a knee replacement if we get into the knee and we find either other compartments have too much arthritis and or there is no ACL and the knee is unstable, or there's other issues going on, then we need to have as a backup the total knee replacement components so that the patient under the same anesthesia will get the right operation and will come out. Patient selection, just like any operation, is one of the most important issues, and a person who does both partial and total knee knows which ones to put through a partial replacement, which one through total. Surgeons who don't do partial knee replacement, they will only offer you one operation, and that will be total knee replacement, which you may or may not want to have. So in this day and age where our patients are so well informed and they know so much more, I think it's very important to have an intelligent conversation with the patient and do the right thing for that patient. And again, I am grateful to you for logging on today and listening to me. I will stop here, and of course, I will be happy to take any questions you may have.
Great, thank you, Dr. Parvizi. One person did ask, are there any age restrictions, weight restrictions, or BMI restrictions?
Great question. No, not in my books. The younger you are, the more likely I am to offer you a partial replacement. But I would do partial replacement in an 80-year-old, and I will do partial replacement in a 40-year-old, as long as the arthritis in the joint is only confined to one compartment and not the other. As for BMI, no, there isn't. But as the BMI increases and it goes beyond 40, 45, both the partial as well as the total knee replacement have less of a success. So we would usually not offer a partial knee replacement to somebody who has a BMI over 40.
Great. What are post-operative restrictions?
None. So with a partial knee replacement, you can do anything you want. You can kneel, you can run, you can jog, ski, golf, etc. With a total knee replacement, you may not be able to run that well, but you should be able to do just about every other activities that you wish to enjoy. And the other thing about the partial is that 4-bar linkage that I spoke about, that provides you with better stability of your knee. So if you're like a competitive skier, you're much more likely to be able to get back to competitive skiing if you have a partial knee replacement than if you have a total knee replacement.
Next question, what is involved in rehab and what is the time frame?
Rehab for a partial knee replacement is about 2 to 4 weeks. Rehab for a total knee replacement is 4 to 6 weeks. So partial has better return to function and faster.
Great. Next question, how long do I have to wait for surgery, partial or total, after I have a joint injection?
That's an evolving science and a good question. Right now, majority of us would prefer not to do a replacement within 3 months of a steroid injections. And the person who's asking that obviously understands that that's because the risk of infection is higher when you do a replacement in a patient who had a recent injection. But that's not set in stone and is definitely not scientifically proven beyond doubt. But nonetheless, it's a precaution that we are taking currently. And if somebody obviously had a break or a fracture and they had this injection within 2 weeks or so, we would still do that operation. But in an elective case where we have the luxury of time to wait, we usually like to wait for 3 months.
Okay. How do you determine how much of the knee has been impacted by arthritis?
Yeah, there are 2 ways to do that. One is obviously X-ray, and the other is MRI. So if the X-ray shows complete arthritis in all 3 compartments, you don't need an MRI because that just shows too much arthritis for you to be a candidate for partial replacement. But if we did the X-ray and we can't quite decide whether there is or there's not any arthritis in the outside compartment or behind the kneecap, in that sort of a circumstance, we do sometimes get an MRI that gives us more detailed information. An MRI also shows us whether there is or there is not the ACL or PCL intact.
Great. Let's see. Can a patient go back to tennis? And if so, how long after surgery?
I would prefer the patient doesn't go back to tennis for 6 weeks. Some patients can go back and play doubles, for example, within 4 weeks. But usually we say 6 weeks. But can they play tennis after knee replacement and partial knee replacement? Yes, absolutely.
Okay. How long is the hospital stay, or is it a same-day procedure?
Same-day procedure for partial. About 20% of total knee replacement patients go home the same day, but about 80% of them stay one night.
Okay. Are there preparation classes before surgery?
Yes and no. We give information, and usually, fortunately, now on the internet and on various sites that we can refer the patients to, there's a lot of information on how to strengthen your muscles with series of exercises. But there is not a formal physical therapy prior to operation, because for those of us who've had knee arthritis, we know that it's very painful, and having physical therapy isn't always very effective.
Okay. Next question. What can you say about how you determine when either procedure is required rather than ongoing steroid treatments?
Yeah, so steroids work well initially when somebody has arthritis. And by the way, there are people who respond well to steroids, and there are people who don't respond that well to steroids. So we have what we call responders and non-responders. In the responders, steroids work well for a period of, 3-6 months. And you could repeat that. Maybe you could do that, twice, 3 times. But there comes a point where arthritis is so severe and steroids stop to work. In that sort of a circumstance, it's important to think about surgery because nothing else really at that juncture is likely to work.
Mhm. How far out are you scheduling surgery?
For myself, as you mentioned earlier, I see patients in Malvern, also in downtown, but I operate in Ben Salem facility as well, Rothman Orthopedic Specialty Hospital. In Rothman Orthopedic Specialty Hospitals, we do have openings. If I sometimes get very busy, we can open up an additional OR. So usually we can accommodate you within 2 to 3, 4 weeks at most.
Great. How long does a partial knee replacement last?
So if it's done properly and it's done by a surgeon who knows how to do them and everything went well, you could potentially have that lasting 2, 3, 4 decades. A long, long time. There's there's a lot of questions on my website as well. Should I be going through some of these also?
Oh, do you see something that I don't?
Yeah, I am. So I'll very quickly go through them while you're looking at yours as well.
Thank you.
Sure. Is patellofemoral arthroplasty effective in returning good function? Yes, it is, but it's less successful than medial or lateral compartment replacement, but it can be. And there is a lot less patients who have just arthritis in patellofemoral joint and elsewhere. So patellofemoral arthroplasty is done less, and because of that, its success is not as much. How do you strengthen your hamstrings if you've had TKA done twice? There are exercises, what we call isotonic exercises, where you can actually put your back against the wall, bend your knee and hip 90 degrees, and sit in that position. That's probably one of your best exercises for quadriceps and hamstrings. And that works really, really well. Can you determine ahead of time how many compartments are affected by arthritis? Yes, you can. 95, 96% of the time we know whether you are or you're not a candidate for partial. And, like today I was doing many. One patient was definitely a candidate for partial, but insurance wouldn't allow us to do the partial. So unfortunately, I ended up doing a total replacement for her. But I knew ahead of time that she definitely could get away with a partial replacement. I have 2 partial knee replacements that are now 17 years old. They're getting weak, mostly because I abused them. I'm a caregiver for my husband and was wondering if partial replacement can be redone with another partial replacement. Yes, for sure. They can be redone for another, as long as the initial ones that were done 17 years ago didn't take out too much bone. If they did, then that becomes a little more difficult than if doing a total replacement at that point. So the answer is yes, they can be. Do you do patellofemoral arthroplasty in absence of arthritis in the other 2 compartments? Is it effective in returning patients to back? Right? Yeah, so if you've got only patellofemoral arthritis and the other 2 compartments are pristine, yes, then you can have a patellofemoral replacement, and sure, you can get back to all of the exercises that you just mentioned. And then the last one here, can a partial knee replacement be performed when there has been prior tibial plateau fracture that resulted in severe arthritis primarily in lateral compartment? Yes, absolutely. In fact, that's one of the best indications for doing a partial knee replacement. Great, Cassie. These are mine. I answered. Thank you.
Thank you. Just 2 more that came over and then we'll wrap this up. So how often does insurance, or what type of insurance, insist on total instead of partial knee replacement?
Yeah, that's a great question. I honestly don't know. I don't even know what insurance the patients have, but we sometimes have to get on the phone and try to explain to the insurance company why we're doing a partial. It's rare that we have to do that, but we see that maybe once or twice a month. And I don't know which particular insurance was the culprit today for this particular patient. But Medicare isn't usually giving us a hard time. It's usually one of the private payers.
Okay. If given a choice between a repeat meniscectomy or a partial knee replacement, which is preferred?
Well, that depends on how much arthritis that person has. If that person has minimal arthritis and it's only a meniscus problem, then I think meniscus issue needs to be addressed, whether it's a meniscal repair or meniscectomy. But if there is already some degree of arthritis in that compartment, and the patient, by the sound of it, has already undergone some arthroscopic intervention, then I would be leaning more towards partial replacement than repeat meniscectomy.
Okay, and last question. If someone had a knee replacement in the left knee a few years ago, is it likely the right knee will need it as well?
No, that's a great question. Not really, not necessarily. You could have had a tricompartmental arthritis in one knee, and now you only have a partial issue. So that's how we get that cohort that I told you about, cohort of patients who've had a partial on one side and a total on the other side. So you can have a partial arthritis on one side and a tricompartmental arthritis on the other.
Great. Thank you so much, Dr. Parvizi.
Cassie, thank you so much.
Just a reminder, if you do need to make an appointment with Dr. Parvizi, please use our VIP line, the 610-480-6584 number. And if you have any other questions, you can just respond to the email that you registered under. So, all right, thank you very much.
Thank you so much. Thanks, everybody. Bye-bye.
Right.
Bye-bye. Bye.